Hello, my name is Christina Delimpalta and I'm a surgical registrar at the Norfolk and Norwich University Hospital. Today I'm going to talk to you about the robotic Alpps procedure as part of the International Laparoscopic Liver Society Congress and whether robotic Alpps is a procedure of the future for a lot of our patients. The background is that Alpps, which stands for Associating Liver Partition and Portal Vein Ligation for Stage Hepatectomy, was initially developed to achieve resection in patients with predicted small volumes of future liver remnant. As we all know, due to this, it leads to rapid FLR hypertrophy, but it also carries high postoperative mortality and morbidity and is technically an extremely challenging procedure. The feasibility and benefits of minimally invasive liver surgery have become very evident in the recent years. They have been well documented in literature, and such approaches might benefit Alpps candidates, which was the reason for doing this research and presentation. Additionally, in recent years, there is increased experience in robotic liver resection, and therefore there is hope that it will be the future, and cases of robotic Alpps have been indeed performed with success. In order to give this presentation, I have reviewed all current published literature. Robotic Alpps has been performed since 2015 for multiple indications, most commonly for colorectal liver metastasis, however, also for intrahepatic cholangiocarcinoma and HCC. The technical advantages of the robotic technology over a conventional laparoscopy and open surgery have no doubt translated to great benefits in those Alpps procedures. There is magnified high definition, a three-dimensional steady view of the stereotactic camera, and all this is combined with the use of articulated instruments with 7 degrees of freedom and access to tight spaces that were previously not possible with the non-bending laparoscopic instruments or even open surgery. This, of course, allows for very precise tissue dissection and gentle manipulation of the liver. The vascular structures are more easily identified, and any bleeding from them can be either fully prevented or even promptly controlled. Therefore, there is smaller risk to patients from catastrophic hemorrhage, which is one of the biggest concerns of Alpps in its nascence, but it can also increase the percentage of those who can successfully proceed to stage 2 completion. The rates of other postoperative complications such as biliary fistulas can also be minimized in this manner, and we all know that precise vascular control is especially important when dealing with the all-important complicated right hepatic anatomy. Additionally, there are other maneuvers, such as the liver hanging technique and the anterior approach, which have been discussed in previous Alpps. These are more feasible with robotic equipment. Therefore, there is a huge cohort of patients that can now be potentially resectable. These patients would otherwise only receive palliative treatment, and they include a lot of patients with compensated liver cirrhosis or intrahepatic liver thrombus. Smaller incisions has always mean less abdominal wall trauma, quicker mobilization for the patients, and a shortened postoperative hospital stay. Also, the degree of liver failure after minimally invasive stage 1 has been noted to be less, and so has the overall morbidity and mortality. This is all very promising. However, we have to think of the other side. Although the above data are encouraging and there is definitely a great scope for development, Alpps itself, as well as complex robotic liver surgery in general, are still very limited and have only been performed on a trial basis in very few highly specialized centers. The learning curve is undoubtedly very long. The number of cases performed is very small, and in order to draw definitive conclusions, to make decisions about who are our candidate patients and how to achieve optimal patient selection, we need to have many more cases and studies. There is also an ongoing concern in the community about achieving R0 resections with robotic surgery, and that is another major factor to be considered in future. Therefore, overall, so far it has been shown that robotic Alpps is feasible and safe. Its postoperative results have been compared to those of the open-air laparoscopic procedures, and the early data show that there is a decreased complication rate. However, Alpps in general is still very nascent. The learning curve for complex robotic liver surgery is very prolonged, and operations of this nature take place only in very few specialized units. Therefore, we do need further studies to establish clear indications, what are the criteria for optimal patient selection, the best operative techniques, and hopefully some guidelines. Thank you very much for your attention.